Hey, beam me up. Hi, I'm Jim Amos. I'm a consulting psychiatrist, and we're going to do a quick run through of some basic consultation-liaison psychiatry issues. In this slide set, there's only going to be a dozen slides, one of which is the title slide, and one of which is the reference slide. So it'll be quick. Very often, psychiatric consultants are asked to help with certain crises such as suicide risk assessments and violent patients, as well as medication management questions, as well as disruptive kinds of behavior. Often we're asked to do suicide risk assessments, and this involves assessing risk factors and protective factors, putting together a suicide safety plan and discharging to a safe environment with quick psychiatric follow-up, or involuntary psychiatric hospitalization if necessary. Managing the violent patient in the general hospital requires a carefully considered plan involving containment and safety, assessment, verbal de-escalation techniques, some kind of intervention, and possibly takedown and restraint if necessary. Consulting psychiatrists are often asked to help manage difficult, complicated psychiatric medication regimens that may involve continuing medications that could affect cardiac conduction times, possibly leading to arrhythmias, as well as starting clozapine, which must be managed by a psychiatrist. What are often called abnormal illness affirming behavior disorders are issues that our colleagues in medicine and surgery would like help with from psychiatric consultants, and they run the gamut from somatization to conversion to malingering to factitious disorder, and the latter involves some sort of lying to doctors. Very difficult situations which must be handled diplomatically for all concerned. Patients with personality disorders often are very challenging in the general hospital because they are persons with inflexible, maladaptive, interpersonal interactional styles that also have on top of them a medical stressor. And it's important to adjust one's expectations of oneself and of the patient accordingly so that conflicts are kept to a minimum. Commonly, psychiatric consultants are asked to assist in decisional capacity assessment, the ability to express a choice, understand relevant information about one's medical condition and the treatments offered, the ability to appreciate the significance of the consequences of one's decision, to manipulate information rationally, and to express a consistent choice are the bare bones of decisional capacity assessment. Managing delirium is an important question that our colleagues in medicine and surgery ask us to help them with. And it involves knowing how to recognize and even prevent delirium. Using the confusion assessment method and the mini-cog, which includes a clock drawing task, can be the quickest ways to get a start on controlling delirium in the general hospital. Catatonia is a puzzling, fascinating, and potentially life-threatening condition that can be a variant of delirium and a feature of many medical and psychiatric syndromes. Getting control of the syndrome starts with recognizing what its features are, usually muteness and immobility, and knowing that an IV lorazepam challenge test might be the quickest way to unfreeze somebody and save a life. Another way that consulting psychiatrists can be helpful in the general hospital is differentiating depression from demoralization, which is, in the patient's own words, often feeling that one is sick and tired of being sick and tired. That is usually not responsive to antidepressants and responds more to supportive psychotherapy. Well, this is the last slide, finally, and I've used quite a lot of references in putting together this presentation. On the other hand, This is also an opportunity to plug my book. Just because it's old doesn't mean it's not useful. Thanks for listening. Hey, beam me up.